We will proceed to the fourth and last abstract this morning, which will be presented by Dr. Abdurrahman Al-Rashid. Dr. Abdurrahman is a consultant rheumatologist at King Abdulaziz Medical City. He has a special interest in connective tissue diseases and vasculitis. He completed his training at Thomas NHS Foundation Trust in 2019, and his topic will be about PPI-induced subacute cutaneous lupus, clinical characteristics and outcomes. Welcome, Dr. Abdurrahman.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. At first, I would like to thank the organizing committee for accepting my abstract. To start, I have no conflict of interest. We'll start by introduction. As we know that subacute cutaneous lupus is one of the spectrum of manifestation of lupus. It's presenting as non-scarring photosensitive rash that usually it's involving the upper chest, the trunk, the upper back, and the extensor surface of upper limb. 85% of these rash is a photosensitive rash. Initially, the initial report about the drug-induced subacute cutaneous lupus was by Reed et al. In 1985. He reported a cohort of 5 patients who developed SLE while on thiazide diuretic, and all of these patients improved completely after stopping the culprit medication. The hypothesis at that time, this is a photoactive medication that reacts in patients with anti-SSA positive. And from that time, a lot of reports came out. Up till now, we have more than 40 drugs that linked to drug-induced SLE. Mainly thiazide diuretic, some antibiotic, antihypertensive, mainly calcium channel blocker, ACIs, and sulfonylureas. We know that PPI is a common medication that is prescribed commonly by rheumatologists, especially when the patient is on a higher dose of steroid. When we collected the data, we came with an idea that why not compare it with a control group of patients with primary SLE and to see what are the clinical or laboratory differences between the two groups. Is there any clinical or laboratory indicator that can help to, or support the diagnosis of either of the diagnosis? So we collected the data of 64 patients from 2009 till 2019. This is the largest cohort of patients with BPI-induced SLE. And the reason for this, because this is a multidisciplinary clinic receiving referral from all the nation in UK from either rheumatology or dermatology side. The clinical details include if there is any background of SLE or SCLE, or the patient is naive and just recently developed these lesions after initiation of PPI. The time from start, the time of this rash from starting the culprit medication, and the time for resolution, and the immunological profile. This is our result. We can see that the BBI group is slightly elderly than the patient with primary SLE. This is probably because the elderly patient is in polypharmacy, and the indication for BBI is more in this group. There is no significant gender between both groups, and we have 3/4 of patients with BBI SLE. They had a baseline SLE. In regard to the immunological profile, there is no statistical significance between both groups. There is some predominance anti-SSA in the patient with SLE. This is well known, but unfortunately, we don't have the full immunological profile for most or maybe half of the patient. As I said, because this is a referred clinic. In regard to the eosinophils, it was normal in both groups, and this is support that this is a real drug reaction rather than, or drug-induced disease rather than a true allergic reaction. Extent of the rash, this is very important, and we found that lower limb involvement could be a pointer toward drug-induced SLE with a significant p-value. The median time to presentation is ranging between 3 weeks to 12 years, mainly a few months or up to 8 months. This is the most common, or the median time. While the resolution, most of the patients describe immediate improvement within days of stopping the culprit medication. The medication were stopped in 34 patients, while 2 patients continue in the treatment because of GI bleeding. In regards to the treatment, more than 50% they improved with stopping the culprit medication with short course of topical steroid or topical tacrolimus. Around 30% they used concurrent oral steroid, and less than 10 patients they were on conventional or biological DMARDs. We had 2 patients, they present with a very severe form of SLE in form of toxic epidermal necrolysis, and both of them required ICU admission for a few weeks, and these 2 patients were managed by higher dose of steroid and DMARDs. There is no mortality in this group. And we have 4 patients who were challenged or exposed to PBI, and they developed similar type of lesion, more rapid onset, and 2 of them were re-exposed to different PBI. So this is support, it's a class effect rather than individual drug effect. This is one of our patients. She's 45 years old. She has lupus and SLE since the age of 24. And she has positive SSA, and she developed this typical SCLE rash after started or shifted from ranitidine to omeprazole. Classically, in this group of patients, the rash is very angry, itchy rash, which is, again, might be a pointer or a hint that this could be a drug-induced rather than a primary. We see in figure B complete resolution after 2 weeks of stopping the omeprazole. This is a 34 years old lady. She presented with a severe form of SLE in the form of TAN, and she was admitted to ICU for a few weeks, and she improved smoothly after stopping the culprit medication and started on steroid plus belimumab. So in summary, PBI-induced SCLE is a common and elderly, mainly seen in Caucasian. The appearance of lower limb involvement could be the pointer or characteristic to allow to differentiate between the primary SLE form or drug-induced. Anti-Rho 60 or Rho 52 may be associated with this phenomena. This is a class effect rather than specific medication related. We need to strengthen that BBI is not contraindicated in patients with SCLE. It's a common medication. This is a very, very rare adverse event of this medication, but we should keep it in mind, especially if there is a lower limb involvement. Thank you.